T4 friends, it is Alana Bree, and I am so happy to be here with Dr. John Browning. He is a total rock star, as all of our T4 speakers are, but he's extra special to me in the fact that he was basically the one that welcomed me to Baylor as a new faculty member. He was a dermatology resident there and our very first pediatric dermatology fellow at Baylor, Texas Children's, and he started a great tradition there. So I have so much respect for John and just all the things that he does as a person and as a physician. And I'm just so glad that I got to be a little part of his journey. So Dr. Browning is a rock star in so many ways, but he is triple board certified. There's not many people running around that can say that in peds, in dermatology, and pediatric dermatology. He is an adjunct professor at UT Health in San Antonio, as well as UIW School of Medicine. And then Dr. Browning, in addition to having his MD and all the great training and board certifications, he also has his MBA from Rice University. So again, amazing rock star in so many ways, but he, in that role, has started his own clinic. And how many sites do you have, Dr. Browning?
Four.
Four sites?
Almost five, but four main sites.
Oh my goodness. Okay, 4 main sites for Texas dermatology. So I'm sure that if you're smart and good with patients and you're looking for a job, you might want to reach out to Dr. Browning. So I would highly recommend working for him because he's just a great person all around. And I'm excited to learn with him tonight and all of our people logging in now and who are going to be watching this asynchronously later. We're going to be talking about Aplasia Cutis, which I think is an important topic because it tends to strike fear in a lot of people's hearts when they see it. And I think that we as dermatologists, especially pediderms, can bring a lot of calm to the situation and a lot of insight. And again, developmental anomalies are fairly rare, but it's also important to know the difference. So I'm excited to learn from Dr. Browning along with y'all. I'm going to black out my screen and just watch along and just turn it over to the master here.
Well, that's way too kind of an introduction. I really appreciate it. But I am so thankful for this opportunity to talk. It's so hard to clear my schedule. And it was amazing that it worked out. I kind of panicked and texted Dr. Bree earlier that I might be running late, but I'm here. And one of the reasons why I actually gave this talk a few years back at the AAD, and the reason I wanted to learn more about this topic is because of working with Dr. Bree in the OR and doing surgeries as a fellow. And I was so thankful for that surgical training because pediatric dermatologists and dermatologists are very equipped to be able to handle a lot of things that we might otherwise send to our plastic surgery colleagues. But you don't want to get into trouble with something that shouldn't be excised, like perhaps a midline dermoid cyst, which we'll talk about shortly, and about why we might not want to go straight to excision. So I titled this Aplasia Cutis and Other Developmental Anomalies because Aplasia Cutis is one of the most common ones. And, sometimes you'll get a panicked phone call from the OB and they're like, oh my gosh, you got to come right away. Well, it's really not an emergency. But, there's some different things that we do to work these up, which I'm going to talk about in this talk. So without further ado, I'm going to move forward. No conflicts of interest. And we just really want to focus on evaluating midline defects, know when imaging is indicated, and develop a plan for treatment or referral. So what is spinal dysraphism? We kind of hear that term a lot. What does it mean? That's really just sort of a very general term referring to a group of developmental abnormalities in which there's defective closure of the neural tube. There's an incidence of 0.05 to 0.25 per thousand live births. So, not really all that uncommon. The closed form or spina bifida occulta is one of the most common types of spinal dysraphism, and it can be easily missed because if you look at the spine, it looks normal. But there is a congenital absence of a spinous process with neural tissue just below a layer of intact skin, and that, of course, can lead to problems. if it's not caught. The open form is spina bifida apert, which is just a very obvious at birth. You're going to have exposed neural tissue, and that is going to need to be repaired before that child ever leaves the hospital. And of course, they're the ones that often have symptoms early on, whereas with the occulta variant, you can catch that and you can actually hopefully prevent complications by treating early. So development of the CNS is very early. It's around day 18 post-conception. So this may even be before a lot of women realize that they're pregnant. So it's happening very early on. And there is this process called gastrulation, which is the basically pouch that forms, and then neurulation with the actual neural tube forming. And there's a primary and secondary process, which we'll talk about in a couple of slides. And this is complete by day 52 post-conception. So before 2 months in the womb, this is formed. Defects during primary or secondary neurulation can lead to spinal dysraphism, and then you have to have disjunction that will occur as well. So we'll talk about gastrulation first. This is where that bilaminar embryonic disc becomes trilaminar. So you go from 2 layers to now 3 with an endoderm, which is going to be the future gut lining, the mesoderm, which will be your future muscle, bone, cartilage, vasculature, and dermis, and the ectoderm, which will form your future epidermis, your skin adnexal structures, and your nervous system. You'll then start to have the neuroenteric canal forming, and disorders that can occur at this time would be split cord malformation and neuroenteric cysts. And you can see a schematic here of that process of gastrulation, where you have your neural plate, which will start to form the pouch or pocket, which eventually turns into the neural tube, and you get the separation of your 3 different layers. So during primary neurulation and disjunction, you're having the formation of your brain and spinal cord all the way down to your midsacral region. And there's a zipping process that's occurring, and this is dependent on folate-dependent enzymes. So that's why you'll see cases of neural tube defects being much more common if there's a folate or folate deficiency. So, and then mesodermal cells will form the notochord. This will induce the ectoderm to differentiate into neuroectoderm. You'll have that neural tube forming with a zipper-like fashion bidirectionally, and it will separate from the surface ectoderm in a process known as disjunction. So if you have premature disjunction where it doesn't separate completely, that's when you'll have a lipomyelomeningocele, and this may come to our attention as dermatologists because they may not know what it is. They may not know if it's vascular or what it is, if it's just a lipoma. So we may be the ones who can help make that diagnosis. You can have incomplete disjunction where there's just still attachment, and that can show up as a dermal sinus, which can be just a very simple dermal sinus, or it could have some hair around it or a lipoma around it. And then you have your cephaloceles, which can occur from impaired interposition of mesoderm between the ectoderm and neural tube. And I've got pictures of all this to show you. During secondary neurulation, you're having formation of the actual spinal cord canal to the midsacral region, and all of those multipotent cells will coalesce and form the tail bud. You'll have canalization occurring to form the second neural tube, and defects can lead to a tight phylum terminale, which can cause a tethered cord. And then this diagram kind of helps to perhaps explain this a little bit better, where you have I shouldn't say explain it better, but it just classifies it. So you've got your process at the top, you've got gastrulation with establishment of your 3 germ layers, and the dysraphic condition during this period would be your split cord malformation, your neuroenteric cysts, anterior meningocele, Then you have your primary neurulation where you're actually forming the neural tube, and the dysraphic condition would be your open dysraphism or myelomeningocele or meningocele. So this could, we could be, called to help diagnose these. Of course, if it's an obvious case of open spina bifida, they probably know exactly what it is. We may never see those cases. Next, during disjunction, when you have separation of the neural and cutaneous ectoderm, you can have incomplete disjunction, which would be that dermal sinus tract, and those should be properly diagnosed so that they don't become infected and potentially lead to meningitis or other problems. And then you can have your premature disjunction with like a lipoma or a lipomyelomeningocele. During secondary neurulation, where you're having formation of the terminal spinal cord, conus, and phylum, you can also have lipomas that'll form during this time. That's why if we see a sacral lipoma, it is cause for concern, especially if it's accompanied by a secondary abnormality. You can get that thickened phylum that may lead to a tethered cord, and you can get a myelocystocele. Let's see. Okay, thought I skipped a slide. All right, so we're going to start back at the top and talk about cranial dysraphism and what can happen during cranial closure. So you can have a cephalocele, and that would be an open process where you can actually see basically brain exposed and sort of a cystic-like structure, or you can have a occult dysraphism, which we see more often. This is where you're going to have heterotopic neural or meningeal tissue. So you may have like a capillary malformation or like a port wine stain looking structure on the scalp, and that may be accompanied by cutis aplasia, or you may have a lipoma there, and that would definitely be a sign that you need to look deeper. You could have a dermoid cyst or a sinus. Warning signs are going to be when there's overlying hypertrichosis. Again, if you have the capillary malformation, which would be a sign of that there's a secondary hit. So the likelihood of there being dysraphism goes up. If you have hair color around cutis aplasia, that's often a sign of heterotopic neural tissue. And we want to get an MRI to be able to really evaluate these. It's going to be the most sensitive for assessing intracranial connections. CT scans basically useless. You might be able to see like a defect in the bone with CT, and then an ultrasound is not going to be that useful on the head unless it's just done very, very early on in life. And so what does a cephalocele look like? Well, it's congenital herniation of intracranial structures through a skull defect. So basically, like I mentioned, you're looking at visible brain. A meningocele is going to be meninges and CSF, and encephalocele will be the brain tissue, meninges, and CSF. These are much more common occipitally, 70 to 85%, but they can occur anywhere. That patent intracranial connection allows for enlargement with increased intracranial pressure, such as Valsalva or crying. So that's actually a really good way to assess it, is to see what happens during crying, or at least get that history if the baby's not crying. That could be a really helpful sign. That may be something that gets asked like on a board is, how would you know if this is, if this is changing with crying, if it's getting larger with crying, then that would help you to make that diagnosis of it being a cephalocele. And then you've got anterior cephaloceles. So this could be a frontoethmoidal with an external nasal nodule. You can have basal with an intranasal polypoid mass, or you can have nasal root broadening. And there may be a hair collar sign, capillary malformation, or overlying hypertrichosis, which of course would be a very helpful sign to suggest that this dysraphic process has occurred. These are going to be handled typically by neurosurgery or otolaryngology so that they can be properly excised without further complication. this is a myelomeningocele. We're probably not going to get consulted on this unless they're just worried that this is vascular, because it does have that red appearance. But obviously we want to get imaging, which would really secure the diagnosis. We don't want to be doing a punch biopsy. That's going to lead to a lot of problems. You can see a nice schematic here of what's actually happening between your vertebral column and your spinal cord. So you've got the lipomeningocele, the first picture on the left, and then that meningocele, and then you have a myelomeningocele on the right. And it really just depends on kind of what's present. So heterotopia is something, like I mentioned, we probably will see more often. It may be a more subtle sign. It may not have gotten picked up early on, or it may have been ignored. They may just think it's a birthmark and they're coming to see us because they want us to just shed some light on it. But this is ectopic neural tissue without an intracranial connection. Some people call it an Atretic meningocele. So this may, you may have a scalp with like a capillary malformation. You could have Aplasia cutis or lipoma, and then it may be sort of soft and squishy underneath, which would be a pretty good sign that there's an Atretic meningocele there. You can get an MRI to help you see better. Some people do get these excised if they're uncomfortable, like if it's tender. But of course, if it's really large, it may be difficult to excise. You have to be careful to not take out too much of the actual scalp skin if you're excising these, because you don't want to leave, a really large scar in their place. You can also get a midline exophytic nodular or cystic mass. And you can have heterotopia covered in normal skin or have a bullous appearance. So this would be membranous aplasia cutis, or a form frust of this. So unlike other forms of aplasia cutis, which are thought to be more spontaneous, if you have that membranous aplasia cutis, which has a really nice circular appearance, and if you see these babies early on, like on day of life 1, you'll often appreciate the bullous nature of it, but eventually that bullous skin just becomes adherent onto the aplasia cutis, so it forms a smooth scar. You can have that. You will have alopecia over the area of aplasia cutis, but you may have a hair collar if it's membranous aplasia cutis and you've got heterotopia there, or you could have a capillary malformation. So MRI is going to be very helpful to evaluate that, because you'll really be able to see the neural tissue better. And then this is just a nice example of a little baby girl who had this, capillary malformation on the scalp, and then right in the middle there was an area of aplasia cutis that had healed. It's just scarred over, and then the hairs are kind of thick all around it. And it's actually not midline. It's kind of a horrible picture, but it's basically to the right of midline. And so there was no intracranial connection. I mean, this is the kind of thing that you could, get an MRI to just make sure that everything looks okay, but they may not even require any additional treatment. The only reason to go in and do any excision of any heterotopic neural tissue is just if it's getting inflamed or irritated. And of course, you'd want to have imaging before anything like that was done. And the capillary malformation will be covered up with hair, so you certainly don't need to treat that. Here's a picture of that bullous aplasia cutis. So if you're lucky, you'll see it looking like this, although, like I said, it's kind of rare to see it like this. Usually it's already adherent. If you do see this bullous aplasia cutis, just leave it alone. You definitely shouldn't be popping it. It may end up just rupturing on its own, or ideally that fluid will just absorb and the membrane will become adherent to the defect. These can be excised when kids are older. So if you have a large area of aplasia cutis congenita that just doesn't look very good and they want to have it removed, it can be excised, and that can either be done, by a dermatologist who does that, or a plastic surgeon. You don't really need to go see a neurosurgeon unless you're concerned that there's some sort of ectopic neural tissue or midline defect. But you should probably get imaging anyway before that referral. And then this would be non-bullous aplasia cutis congenita. So this is not due to a neural tube closure defect. This is just thought to be spontaneous, and there's kind of a lot of different theories as to why the non-bullous aplasia cutis congenita forms. But what you can appreciate about this picture is the large size. It tends to be very jagged. In this particular case, it's multifocal. It's not round and smooth like the membranous aplasia cutis. All right, so moving on to the Atretic encephaloceles. So these are midline masses with no intracranial connection, most commonly located in the nasal area, or extranasal, intranasal, or combined masses. These are often referred to as the nasal glioma. So it can occur in other locations such as the scalp, oropharynx, and orbit. It's not compressible, and MRI will be helpful. So if you're so you may find that MRI, of course, will be helpful. You may end up referring to neurosurgery or ENT. And I think I have a picture. Yeah, there's a nice picture there, so you can see it. So it's non-compressible. It's firm, and you can see that there is no actual connection. So it's not going to change. The size of it's not going to change with prying or Valsalva. Now, dermoid cysts, this is an area that's near and dear to my heart because I do excise dermoid cysts, typically under anesthesia, unless it's an older, teenager or an adult. And these often have to get excised because they just get really large and they're unsightly and they're uncomfortable. They don't have to be excised. They are actually at very low risk of rupturing. They tend to be pretty deep, and they're not really super at risk for rupturing like an epidermoid cyst would be. But these dermoid cysts are due to entrapment of cutaneous tissue along the embryonal fusion lines, most common on the lateral eyebrow. They are congenital. They may not be immediately obvious at birth, but they certainly become pretty obvious within the first few months of life. These are cysts that are lined by epidermis and associated adnexal structures. So if you remove them, you may see those hairs in them because of the hair follicles. They do tend to kind of have that sebaceous content, not unlike an epidermoid cyst. And you can have eccrine and apocrine glands as well. But if it's midline, there's possibility of intracranial extension estimated to be about 45% of the time. So I always image midline dermoid cysts, and usually, even if the imaging looks clear, I usually still refer those out to ENT or to neurosurgery or plastics so that they can excise them, just in case that intracranial extension was not seen. But if it's lateral, there is no risk of intracranial extension. So, you can feel confident to excise those. And I don't even get imaging if they're lateral. We just, if it looks like a dermoid cyst. So now sometimes I will get a ultrasound, because ultrasounds are easy to do. They don't require anesthesia. You can do it at just a local imaging center, and that'll just confirm, it's a cyst, and it's deep and could be consistent with a dermoid cyst. They can also measure blood flow. So if you're concerned it could be an infantile hemangioma, you can usually differentiate that pretty easily with ultrasound. And you can see a midline dermoid cyst here, right over that glabella. So I would not excise this, but I would get imaging and then refer out. The dermal sinus is another thing that we see a lot as dermatologists, and especially as a pediatric dermatologist. These are these small 1 to 5 millimeter tracts. They can be by themselves, or you can have it next to a dermoid cyst, but I would say I see them more commonly by themselves. You may have a small tuft of hair protruding from a punctum, that would definitely be a pathognomonic sign. You can get some discharge that could be kind of yellowish sebaceous material, and you can get a risk of meningitis if there is communication with the CNS. So they should get imaged. You do want to get an MRI, and then you can refer to neurosurgery, and they can do a nice excision to make sure that they're closed up and there's no risk of infection. And then here's an example of one. This is a really, kind of a nice example. I mean, I think if anybody saw that, you should know that that's abnormal and should be evaluated and imaged. I think the more, there can be much more subtle dermal sinuses that may not have the hair tuft. Sometimes you get them on the nose, and it can just sort of look like a midline, like almost like an acne cyst, but less inflamed. Okay, so closed spinal dysraphism often has skin abnormalities. So 50 to 90% of the time, it's going to be that skin abnormality that's going to be the clue to the closed spinal dysraphism. It's going to be most common along the lumbosacral area, so we do want to be prepared to recognize these signs and have imaging done, because babies could have a tethered cord and they're asymptomatic until that spinal cord stretches, which is going to happen as they, sometime between ages 2 and 4, and that's when they can start to become symptomatic. You can have associated anorectal or urogenital malformations because of a common cloaca adjacent to the neural tube. So sometimes we'll see these with like a large infantile hemangioma, and then you can have kind of some associated abnormalities like you might see with spinal or sacral syndrome. The tethered cord syndrome will show up with like neurologic. You may have a child who basically loses bladder or bowel control that they were previously potty trained. They may start to trip and stumble. They may have a lot more accidents. And that's how it shows up. So you ideally want to like diagnose it before they become symptomatic, so that when the time is right, that phylum terminale can be released. And this is tethered spinal cord is happening because your conus medullaris, which is the caudal spinal cord, is hanging freely in the canal, and it's stabilized by an elastic band known as the phylum terminale. So during embryogenesis, the cord is growing at a slower rate than the vertebral spinal column. So you have this ascension of the conus, but the tethering will occur because of that thickened phylum terminale and leads to mechanical traction and ischemia as the child grows. So as the as it's stretching and it's tethered instead of growing as it should, that's when you're going to have the traction and ischemia. And you don't, obviously you don't want to have complications from that. So early neurosurgical intervention, and the neurosurgeons don't always operate right away. Sometimes they wait until the kids are a little bit older, but they're going to do it before they're symptomatic and before it's a problem. You can also have retethering that can occur if you do it too early. So they do monitor them closely for that. So, signs of a tethered cord. Well, 2 or more cutaneous signs has a high predictive value, and some signs have a higher predictive value than others. So, neurologically, you might have pain, numbness, or weakness. You can have asymmetry of one side over another, gait deterioration, scoliosis. You can have, urine leakage, recurrent UTIs, incontinence. So those are going to be your signs of when it's happening. But the cutaneous signs obviously are what we really care about as dermatologists. And so this is kind of a helpful schematic where you can see that the high is up at the top. So under group 1, if you have greater than 2 lesions of any kind, that's going to be high predictive value. If you have 1 lesion and signs of spinal cord dysfunction, that's high. A lipoma is a high risk sign, and I do remember a board question once about they listed all these different signs, and it was like, dimple, capillary malformation, hypertrichosis, and then lipoma. And lipoma has a higher predictive value, so that would be the right answer in terms of which one would you be more worried about. And then the dermal sinus as well. You can see, and a tail. That's the tail would just be like a little embryologic remnant. And I think if anyone saw a tail, you're probably gonna get that imaged. So that's a little bit less subtle. But the dermal sinus is different from just a superficial dimple. Superficial dimples really don't have any risk at all. But then as you move down into that medium group, which is going to be group 2, this would be an atypical dimple. So this is probably one that's going to look deeper. You're probably trying to decide if it's a dimple or a sinus, or maybe it's got, you're like, is there possibly a lipoma next to it? If you have like a weird hamartoma, like there's like a collagenoma or something, that doesn't look like it belongs. If you have aplasia cutis, if you've got deviation of the gluteal furrow, that would sort of be suggestive that there might be like a lipoma or a lipomyelomeningocele. And then as you go down into group 3, these are much lower risk, assuming they're occurring by themselves. But that would be a hemangioma, especially if it's a small hemangioma. Now, as you get into larger hemangiomas, especially larger than 2 centimeters in diameter, that's going to be higher risk. If it's a port wine stain all by itself, if you just have some hypertrichosis all by itself, if you have a pigmentary nevus, a simple dimple, that's just, you can stretch it out and you can actually see the base, or a Mongolian spot. So those are low risk. But again, if there's 2 that are occurring together, or if you have one of those, plus you have some potential signs of spinal cord dysfunction, or you've got a lipoma, you definitely need to jump on an MRI. The MRI, and this is saying you can see in the middle, if you're less than 6 months of age, if you're high risk, you should still get an MRI. If you're in the medium or low risk, you can actually still get an ultrasound, because ultrasound is still pretty useful less than 6 months of age, and I'd say especially less than 4 months of age. But once you get past 6 months of age, you need an MRI because of how it's difficult to see past those vertebral bodies past 6 months of age. And ultrasound is a little bit more user dependent. So you're really relying on your tech, and the radiologist may not really be, and you're also relying on the frequency of your ultrasound equipment. So you really may be limited in terms of what you can see. So sometimes you have to pay attention to that report and see if they're hedging and suggesting an MRI. You probably should go ahead and get an MRI. These are some examples of some cases here that, I think that one on the top left, that very large hemangioma, that's very large. I mean, you should just go ahead and get that imaged. But the one on the right would be very low, low risk. And now, unless there's like an area of aplasia cutis next to it or a lipoma, you don't really have to image that. The box C, the tail, that should be imaged, obviously. And of course, that's going to get excised. If you have a large area of hypertrichosis, if it's all by itself and there's not an association, it is lower risk. Although I would say this is pretty prominent. Usually I just see kind of like, clustered hairs, not like such a large, thick area. And then this is just a benign dimple, but something like this may get your attention, or it may get the pediatrician's attention, and you may end up seeing them in the office. Usually we can stretch these and you can kind of clean with an alcohol wipe and see the base. Plus there shouldn't be any discharge at all, unless there's just a little trapped skin in there, but there shouldn't be like yellow discharge or anything like that. So again, MRI is preferred when there's high test probability, but it is limited by cost and unfortunately the need for sedation. And really by sedation, I mean like general anesthesia, like they're out, they can't move during the MRI. And we're talking about, a young child under the age of 1. So there is, some risk with that. But sometimes that's just what we have to do. But you don't want to just get an MRI if you don't need it. Again, the high resolution ultrasound can be useful for younger infants before ossification of the vertebral bodies. But again, it's operator dependent, equipment dependent, less sensitive than MRI. I'm going to go back to lipomas only because this is something that we see all the time. Often if somebody suspects a cyst or lipoma, they are referring them to us, regardless of whether they're midline or not, or how large they are. Isolated lipomas or lipomas occurring in combination with other lesions, mostly with an overlying port wine stain, are the most common midline cutaneous lesions associated with occult spinal dysraphism. So again, for the boards, pay attention to those midline lipomas. Those need to get worked up, and especially if you see a port wine stain with it, that's really spinal dysraphism until proven otherwise. If there is deviation in the gluteal cleft, that's a reliable associated feature. And then you can see these very large lipomas. They don't always have to be this large and obvious, but this is just kind of a nice example. And you can see those MRI images underneath them and what is actually going on below the surface of the skin along the spinal cord, where you've got the associated lipomyelomeningocele. So in conclusion, you're going to consider an MRI for midline lesions if it's a lipoma, if you've got aplasia cutis congenita with hair collar, if you've got a dermoid or sinus tract that's midline, if you've got 2 or more cutaneous findings or a larger hemangioma. But as in all things, medicine is a science of uncertainty and an art of probability. So, sometimes you just have to go with your gut. And if you're worried about a patient, it's never wrong to get imaging. There always are going to be exceptions to what I presented on today. And that is pretty much it. So that was, took about 40 minutes, but it was a lot of good stuff. Hopefully useful for the board.
Oh yeah, clinical practice for sure, because that stuff is going to come up, and it's better to have a little bit of knowledge in your toolkit than to, go into it blind, right? So yeah, and I do, you don't know what you don't know. So I think the more we talk about things that are a little bit more rare and uncommon, because I do remember there was a kiddo at Texas Children's, and like the resident went in and saw it. And of course, it's not the resident's fault. You don't know what you don't know. It's my favorite saying because it's true no matter what, right? In life. And they came out and presented, and it was just like a little telangiectasia that needed laser, and thought it was an easy slam dunk. And there was like a little tuft of hair coming out of this like little pinpoint thing at the end of the nose. I'm like, well, what's this? And they're like, oh, I didn't see that. I'm like, how did you not see it? It's in the middle of their face. Like, did you open your eyes? Like, again, I think as dermatologists, our best tools are our eyeballs and our hands. And use them. Look at every square inch of kids, like they're small. Make sure you just look. Because again, if you don't look, you're not going to see. And if you don't feel, as a dermatologist, I feel like, we do a lot of surgeries and lasers with our hands, but those are our best diagnostic tools too.
Yeah, I mean, our hands can be we can learn more from our fingers than we can from an ultrasound if we can palpate. Because an ultrasound, you're just looking at shadows, but with your fingers, you can feel if it's warm, you can feel if there's depth, and you can definitely push around the spine too. And, often you can feel if there's something abnormal underneath the skin, even if you don't see it.
Yep. So very true. And so I loved all the diagrams and the little algorithm that you put up there. I thought that was really helpful too. Took me back to embryology. So thank you for that. Dusting off some neurons there, but it's important. And when you can visualize it, since we're a visual specialty, I think it does help kind of solidify it so that we know. So great. I thought that was good. And thanks for the few board pearls that you were able to throw out, because those are similar questions. That hair collar sign, they love the hair collar sign for sure. So thank you so much for doing this. We really appreciate you so much. So thank you for making it on time today. Thank you for all you do to help kids love their skin. skin they're in, and we'll see you next time.
Sounds good. Thanks for having me. Really appreciate it.
Thank you.
Bye.
Bye-bye.